So welcome to you all once again for the continuation of the ECG workshop. Very good morning. Good morning to Dr. Sudhir Garu and Dr. Mahendran sir. We thought of having the questions and discuss them today, but I could only give the questions today, the assessment. So the assessment is circulated to your groups as well as to the HOD sir. Kindly go through each one of the questions there and put your mind and answer them to the extent possible. Something is not known or clear, you make a note, we will discuss. And these will be discussed by next Tuesday, which means that we have around 1 week time from now. By Saturday, you make up your mind and send the answers to my WhatsApp. So then what are we going to do? So we will start the second part of the ECG workshop, the ischemic heart disease. Needless to say, this is one of the most important utilities of ECG. In an acute situation, ECG changes are the diagnostic things, and you have to be very vigilant from now on. Of course, every part of ECG is important, more so the ischemic heart diseases. So now I will start sharing the presentation, and let us start off. So we are starting on the part of ischemic diseases today. This is the second part. The third part will be about the arrhythmias. The fourth part will be electrolytes and other miscellaneous conditions. So first of all, we need to understand the coronary blood supply before we go into ischemia, because each blood vessel is supplying a different territory of the heart. So imagine the heart to be a box without the superior and the right surface. So box will have 6 surfaces. This box doesn't have a superior surface and a right-sided surface. So it is left with an anterior surface, a lateral surface, a posterior surface, and an inferior surface. And anterior, lateral, posterior, and inferior. Right side, these two come and merge like that, and superior also it merges like that. So we don't have a superior infarction and like that, and also of course right ventricular infarction can occur, but as far as surfaces are concerned, we deal the heart as 4 surfaces: anterior surface, lateral surface, anterolateral surface, anterior surface, inferior surface, anterior-inferior surface, lateral and posterior, posterolateral. So like that, the infarctions will be anterior, anterior-lateral, anterior-inferior, inferior, lateral, posterolateral. So these are various combinations can occur depending on which blood vessel is affected. So remember, the coronary arteries directly arise from the aorta, right? So the epicardial blood vessels are basically to the RCA, right coronary artery, and then the left coronary artery. This is the RCA here, and the left coronary artery, left main, it is called left main coronary artery, and right coronary artery gives several branches. So there is what is called the sinus node artery, there is the conus node artery, conus artery, and then the right ventricular branches also are there. This is the RV branch, then acute marginal branch, and then the posterior descending branch, which goes below the heart into the posterior part. Okay, right coronary artery basic blood supply is to the sinus node, to the conus of the heart, and then the branches of the right ventricle, and the anterior marginal branch, and a posterior descending artery going to the posterior part, mostly to the right side of the heart. And the inferior surface of the heart is supplied by the right coronary artery. So the left coronary artery also arises from the aorta. And there is a left main. Any disease of the left main will cause obstruction, of course, to the flow in both the branches. So left main disease is always dangerous, and left main disease itself is a different entity to treat. So the left main artery divides into left anterior descending branch and left circumflex. Simply can be called as circumflex also. The circumflex runs in the groove between the atria and the ventricle and traverses to the left border, and then crosses to the posterior side and anastomosis with the right coronary artery. So the anterior descending artery comes down to the anterior surface of the heart and supplies most of the anterior surface and some of the lateral surface. So you look here, the fifth is the main trunk, and 6 is the anterior descending, also called the LAD, and then the 7 is the anterior descending branch middle part. So this is the middle part of it, and this is the distal LAD. So they say there is a disease in the distal LAD, that means here. There is a disease in the middle LAD, here. Yes, the proximal LAD, it is here. Proximal to the first branch. What is that first branch? First diagonal branch. Before the first diagonal branch, it is proximal. Before the second diagonal branch, it is middle. Beyond the second diagonal branch, it is called the distal. So this is important for us because sometimes there will be regional blood flow abnormalities rather than the whole of the LAD being affected. So basically, this supplies the posterior and the inferior surface of the heart. This supplies the anterior and partly lateral. This supplies mostly lateral surface and also to some extent the inferior surface. There is what is called dominance also. In some people, there will be LCX dominant. Some people, it will be RCA dominant. Depending on the dominance, so 30% of people will have LCX dominance. Remaining will have RCA supplies more and more area than the LCX. So as we know, there are 3 blood supplies to our house. The current supply, the 3 phases. Here also God has designed 3 blood vessels here. The reason is because left ventricle being a bigger one, it requires to be served by 2 independent blood vessels. That's why the LAD and the LCX. Remember, both the coronaries, all the coronaries fill in diastole. Why not in systole? In systole, heart is contracting. The blood vessels will not have a chance to expand. So these are the blood vessels which are filled in the diastole. So diastolic pressure in the aorta directly decides the flow in this, not the systolic pressure. Another thing is there is what is called the poverty amidst plenty. What is that? So the heart is supplied full of blood inside the chamber. Inside the chamber, heart is holding the blood, but not a drop of it trickles into the myocardium through the endocardium. Whatever the myocardium has to get, it has to come through the epicardial blood vessels. Like the cashier in the bank, he has got so many notes, some 20 crore lakhs of notes on his table. He is counting and distributing, but then he can't take 1 rupee out of it. Only he will be able to draw the money he is supposed to get it through the bank check, through his salary check. Like that, it is here the poverty amidst plenty. So this is important for you to know that, and let us go. So this is that is a diagrammatic way we have seen, and this is a chart wise. You can see the aorta. The aorta gives rise to LCA and the RCA. We know the left coronary artery divides into anterior descending and the left circumflex, or simply called circumflex also, because there is no right circumflex. Even if you say circumflex artery, it is left circumflex artery only. Left anterior descending branch gives the diagonal branches, also supplies the septum, and this supplies the anterior part of the heart. So the circumflex artery gives the marginal branches, and these marginals supply the free wall, which is called the left wall of the heart and also the apex of the heart. This one. The posterior right coronary artery gives rise to posterior descending artery. This posterior descending artery can be from the right coronary or can be from the directly from the LCA, and this posterior descending artery can supply the posterior part of the heart. This supplies the inferior part of the heart. All this is related to the left ventricle. Whereas the right marginal branches of the right coronary artery, they supply the right ventricle. So the supply of the right ventricle is basically looked after by the right coronary artery. Supply of the inferior and posterior part is supplied by the RCA and the LCX, and the anterior part is supplied by the LCA, and also the septum and the anterior part is by the anterior descending artery. So this is another way of representing the same information. So this is the English of that. Anterior surface, LAD, left circumflex. If you see an anterior infarction, the culprit vessel is either LAD or the left circumflex. Lateral surface, left circumflex, and sometimes partly LAD. Inferior surface, RCA or LAD terminal portion. Posterior surface, either RCA or LCX. Right and left coronary arteries arise from the aorta. At the origin, they are 2.5 millimeters. You know what is a millimeter on the scale? They are just as wide as 2.5 millimeters. At the end of it, the terminal part is only 0.5 millimeters, the intraluminal diameter. how much time it will take for such small tubes to get occluded. These are not like the plumbing tubes which you see for the water drainage, big pipes of 10 inch diameter, 20 inches diameter, and even they are getting clogged. A 2.5 millimeter tube to get arrested and clogged and obstructed with our dosha, vada, idli, non-veg, all fat food, how much time it will take unless we want to keep it healthy? Just imagine. Okay, coronary arteries filled during diastole, and the flow is from epicardium to the endocardium. Flow is from epicardial blood vessel, gives and burrows inside and supplies onto the endocardium. Nothing comes from the endocardium to the epicardium directly. So there are three things that happen whenever there is supply-demand equation is not met. Demand is the demand by the myocardium, particularly left ventricular myocardium, about the requirement of oxygen and in turn the blood. Supply is the amount of blood that is supplied to the left myocardium or the myocardium of the heart. So if there is a discrepancy between the demand and the supply, either the demand increases or the supply decreases or both, it can result in myocardial ischemic heart disease. So we see here three entities. One is called the ischemia, the other is called the injury, the other is called the infarction. You have to understand these terms very clearly. Ischemia, injury, and infarction. In ischemia, there is no tissue injury, there is no tissue death, there is no injury at all, only relative blood supply is lacking and it is crying for help. Such a situation, you only get a T wave change. Ischemia alone says T wave change. If there is an injury to the myocardium, then it results in ST segment elevation, and if there is an infarction, it results in the Q wave formation. Total loss of blood supply is infarction, and relative loss of blood supply is injury, and deficiency in the blood supply but no injury, that is called ischemia. Ischemia in general produces, these are not watertight compartments, these occur together. There will be a zone of infarction, around that there will be zone of injury, and there will be zone of ischemia. Just like you see the umbra and the penumbra that you see in your eclipse, the central part is the eclipse zone and around that is the penumbra. Like that, there is an umbra which is the infarcted zone which shows the Q wave. Around that is the injury zone which is the ST segment elevation, and there is the zone of ischemia surrounding that. The tissue is not totally injured but still suffering deficiency of blood supply. That is shown in ECG as T inversion. What are the conditions which throw an increase in the demand? Of course, anemia. Anemia, why? The quantity of blood is the quality of blood is very poor. Though 5 liters is there, the oxygen carrying capacity is lower, so much so the heart is not able to meet the oxygen demand because there is 8 grams hemoglobin or 6 grams hemoglobin. So much so, anemia is one condition which produces high demand. Exercise. So when you exercise, the myocardium requires more blood in order to work faster and give higher output and heart rate. This is what we do in treadmill test. We increase the demand and through exercise and see whether any one of these things are. Of course, we don't want to precipitate infarction. We wanted to see whether there are any ischemic changes or injury changes are there during your exercise. Left ventricular hypertrophy of whatever cause, commonest being hypertension, aortic stenosis, aortic regurgitation, cardiomyopathies, whatever is the cause of left ventricular hypertrophy, that of course throws a demand on the heart, increased demand on the blood supply, and the supply is maybe normal, but the demand is high and there will be ischemic changes. That is why whenever there is LVH, you see associated strain pattern, you say, or whatever is the ischemic changes because of the LVH. There is no actual injury or infarction, but it is only relative deficiency that is heart is facing because of the increased demand. Likewise, thyrotoxicosis, very understandable hypermetabolic hormone where the heart rate will be higher and the demand on the myocardium on oxygen is also higher, or any other hyperdynamic circulatory state like pregnancy, Paget's disease, beriberi, fistulas, and we have seen one case also, hyperdynamic circulatory failure, hyperdynamic circulatory state. So these are the various conditions. This is not an exhaustive list. There's some of the common conditions that throw a demand for excess oxygen requirement of the heart, though the supply is normal. But there could be also supply is reduced when there is an atherosclerotic occlusion of one or more of the coronary arteries, or when there is a vasospasm, as occurs in a very variant angina, also called the pringimetal angina, or when there is tachycardia also because of the why tachycardia, CBF is reduced, coronary blood flow. We know that the heart fills in, the coronary blood vessels fill in diastole. In tachycardia, what happens? The diastolic time is shortened. At the expense of the diastolic time, the heart rate increases. There is no enough diastolic time for the vessels to fill completely. So there will be a reduced coronary blood flow in case of tachycardia. Aortic stenosis and aortic regurgitation. Aortic stenosis, blood is ejected into the aorta, is less. That is why there is a ischemia or anginal attacks and ischemic heart disease. In aortic regurgitation, blood is ejected all right. It is not staying and coming back. The diastolic pressure in the aorta is very low, 30, 40, maybe even 0. So at that diastolic pressure, the coronary blood flow suffers. So you understand what are the conditions which produce an increased demand, what are the conditions which produce an decreased supply, and a combination of both. What can happen? Ischemia can happen, injury can happen, infarction can happen. Infarction is total necrosis of the tissue because of lack of blood supply, and that throws a Q wave, and around the infarcted zone, there will be a zone of injury where there is the muscle is already damaged and it is weeping. How do I know the muscle is weeping? The SGPT will be more, and the LDH will be more, and the troponin will be more. All the cardiac enzyme markers will be more in case of injury as well as infarction. But they are normal in case of ischemia because the tissue is not yet injured and not crying. None of the cardiac markers are positive. Only the T wave is inverted, here ST segment elevation, here Q waves, and don't think that these occur separately. The combination of them will be seen in the ECG. So let us see now. So ischemia produces ST segment depression with or without T inversion. Injury causes ST segment elevation with or without loss of R wave voltage. Infarction causes deep Q waves with loss of R wave voltage. That is another important thing. As you can see in the previous slide, the R wave is almost absent directly to the QS complex. So when there is an infarction, the R wave, that is the myocardial electricity towards the lead, is reduced. Reduced amplitude of the R wave is again a sign of infarction. Then we need to know what is subendocardial and what is transmural. So you see here, subendocardial injury is, you see the myocardium, left myocardium we are concentrating, left heart. In the left myocardium, this is the total thickness of the myocardium. Okay, and this is the endocardium and this is the epicardium. Subendocardial blood supply is reduced and injury is there. Then you see a classical ST depression. Subendocardial infarction, which is not through and through, not transmural, subendocardial is it is an injury to the subendocardial region of the myocardium. This injury shows ST segment depression. Here, there is no complete occlusion of the injury or infarction of the entire muscle, only part of the subendocardium. Why is subendocardium involved? Why not subepicardium? We know the blood supply goes from this side to this side. So the one that is going to suffer most, earliest, is the subendocardium. Then if the supply is still reduced, then this part also gets infarcted. So whenever there is a demand, it is the subendocardium that shows the injury. That's what we see in your ECG treadmill test. Then the ST segment will be depressed. You find, yeah, there is an ischemia there and there is injury there. But the moment you stop the demand, then again this blood supply is sufficient, and then the ST segment and T waves may return to normal. That's one reason for demand, subendocardial injury. The second one is transmural, where the entire thickness of the muscle of the left ventricle is not getting blood supply and it is dead, practically dead, that is infarcted. And this both throw the enzymes out, and we will be able to see the cardiac markers in the form of troponin T, troponin I, and then the LDH and the CPK, and of course your SGPT, and all the things will raise. And this here, the injury currents on the ST segment region are towards the lead, and you have an ST segment elevation. Don't ask me the electrophysiology part, why there is depression here, why there is elevation, because that requires you to understand more about the electrophysiology. Suffice to know that if it is only injury, that to subendocardial region, it produces ST segment depression, mostly due to increased demand. And there is a transmural, the blood supply is totally cut off to the entire thickness, the current is in this direction, ST segment is elevated. If you see an ST segment elevation, it is transmural. If you see an ST segment depression, it is subendocardial. Okay, this could be due to supply and demand both, or supply is reduced or coronary blood vessel is occluded by an atherosclerotic process and an acute thrombosis. Acute coronary event will be precipitated. Now, the subendocardial region of the infarct can progress on to transmural, or whatever is transmural to start with. Once some intervention is given, the blood supply to this region may be restored, and a small area of infarct will be left. The remaining part of the infarct may only show subendocardial injury. So changes of ST segment depression may become ST elevation when it is progressing, and when it is improving by treatment, the ST segment will return to baseline, or there may be some ST segment depression. So this is in relation to the baseline. This is the baseline. Compared to the baseline, is it depressed or elevated? The question is, how do I know it is depressed or elevated? Only when I compare it to the baseline. Okay. And the ensuing T wave may be inverted or may be upright depending upon what type of changes are there. We will see that. Okay. This is called the fate line of the ECG. So when somebody takes an ECG and calls me up in this one, I'll ask, what is the fate line like? That means I'm talking about the ST segment. If the fate line is on the baseline, then his fate is better. If the fate line is depressed, somewhat risky, if the fate line is elevated, of course it is through and through infarction. And we have now known from studies that degree of ST elevation is one of the important markers of prognosis. 1 millimeter elevation compared to 2 millimeters compared to 10 millimeters, a host of difference is there in the prognosis. Likewise, depression also. They are not only qualitative, they are quantitatively also are useful. And when we want to say it is infarction, at least there must be in 2 contiguous leads. There is only 1 lead suspicious. So we can't really say there is infarction or not. We must have at least 2 contiguous leads, or 2 leads telling about the same story. Suppose I see in L1 and V6, okay, both tell about the left heart, understandable. If I see in AVF and L2, they tell about the inferior part, understandable. So there must be 2 contiguous or 2 related leads. Then only we can say it is a true ischemia or infarction or injury going on. Okay. This is a transmural injury. This is a subendocardial injury. Now, we need to understand. Okay. Just sink in the ideas which I have told till now, and 1 minute I'll give. And this table will illustrate. Now the blood supply can be ischemia, can be infarction. Is it not? Ischemia is, it could be transient or it could be persistent. Transient loss is ischemia, persistent loss is infarction. It could be subendocardial or it could be transmural. Subendocardial transient loss is called the stable angina. Subendocardial supply transiently, and once he takes rest, he is relieved of the pain and the demand is reduced, and then the stable angina. He gets angina only on exertion. Subendocardial infarction, if it persistent loss is there, then it will be NSTEMI. That is non-ST segment elevation myocardial infarction. Basic difference is here enzymes are not elevated, here enzymes are elevated. Okay, because this is ischemia, this is injury and infarction. Okay, and this is subendocardial, and of course ST segment will be depressed in subendocardial infarction, as we have seen in the previous slide. We saw in the previous slide that ST segment will be depressed whenever it is only subendocardial. Okay, whereas if it comes to transmural through and through, that means there is a coronary spasm, entire muscle of the heart did not get blood for a while, very transiently. That is called transient ischemia, which is called variant angina or fringe metal angina. Once the spasm is released, there is no injury, there is no infarction, there will be normal ECG. Many a time we see a typical infarct-like pattern. The moment he is given the treatment, particularly for transient angina, the variant angina, his ECG becomes normal, which means it doesn't require an intervention with the coronary care unit. So that is a transient angina. I'll show you the ECG of a transient angina. It looks like infarction only, but the ECG returns to normal within a few minutes. Okay. Whereas if it is persistent, it leads to ST segment elevation myocardial infarction, also is also the part of the acute coronary syndrome. So what will be my ST segment? It will be elevated. Understandable? Subendocardial ST depression, transmural ST elevation, subendocardial persistent, subendocardial transient. Subendocardial transient is stable angina. Subendocardial persistent is with infarction and injury and enzymes are elevated. This is called non-ST segment elevation. This is also part of the acute coronary syndrome. Suppose transmural transient loss of blood supply is there, no injury, no infarction, occurs in variant angina due to coronary spasm, also called the fringe metal angina. This fringe metal angina was the short notes when we appeared for MD examination. So they gave one short notes, fringe metal angina. None of us are very familiar with the term in those days. So it took a little while to understand what he is asking. And in the Harrison in those days, they are given 6 lines about fringe metal angina. If one has missed reading those 6 lines, the short notes they could not have answered. Luckily, whatever is written there, those 6 lines we reproduced and we made the answer of it. Today, you know so much about fringe metal angina. So all of you are probably familiar with it. So this is a vasospastic angina. There is ischemia only, no injury and infarction. The blood supply is transiently cut off. And what we see is the entire blood thickness is affected. So we say an ST elevation, which returns to normal with treatment. The treatment of this angina is different from the treatment with this angina. In fact, what we give sometimes, we should not give here. I'll tell you about that. Okay. So when there is a persistent loss of blood supply, then it is ST segment elevation myocardial infarction. So now we have an NSTMI, we have an estimate together. These are called ACS along with one other entity called the unstable angina. What is that? We will see in the next slide. So you also need to understand what are the types of angina. It could be an essay question for you. Discuss the various types of angina. Not many people will understand this. Not many people are probably aware of so many ways of looking at it unless you have this diagram. This diagrammatic representation illustration is very easy for you to remember them. So we have what is called a chronic stable angina. We have a microvascular angina. We have an unstable angina. And we have a variant angina. Okay, 4 varieties. Now, what is chronic stable angina? A person doesn't have a chest pain at rest, but the chest pain is precipitated on exertion and relieved by rest and lasts for a few minutes, that's all, few seconds to few minutes. The moment it takes rest, it's up. Why is it due to? It is a dynamic stenosis. That means when there is an increase in the heart rate due to exertion or walking, there is a compromisation of the blood supply, and the microvascular dysfunction is also added. So that is why the pathology is there. In chronic stable angina, patient will be normal at rest. Chest pain typical of angina is precipitated on exertion and relieved by rest or nitroglycerin. This is a typical story. And there will be a sort of crescendo angina. Crescendo angina means a patient who is able to walk 1 kilometer. Now, after some months or years, he says, I can't walk even half a kilometer, I get the pain. The pain threshold is rather reduced. At a smaller distance itself, he perceives the pain. Such a situation is called the crescendo angina. Is it good to have stable angina or not? Stable angina is a warning sign. So if somebody is presenting with stable angina, chronic stable angina for 2 years, 3 years, he has got enough time to investigate himself, take treatment, and then see that he doesn't exert or the beta blockers are given, heart rate is reduced. It is a boon. If somebody presents with chronic stable angina rather than straight away with myocardial infarction, it is a boon. So that is, some people go through the chronic stable angina, then go to crescendo angina, then unstable angina, then non-ST segment, then ST segment. That progression is there. 30 to 40% of the coronary artery disease progresses in that direction. And these are the lucky ones. And these are the older lot. These are the people who have collaterals already established. Who are they? People who present with chronic stable angina, crescendo angina, giving time and no infarction as yet, lot of chances for investigation and treatment. And here the problem is dynamic stenosis and microvascular. There is no atherosclerotic occlusion or rupture of the plaque suddenly and thrombosis. Okay, this chronic stable angina is these are only 30% or 40% of ischemic heart disease is in this category. Who is in this category is again dependent on the genetic nature and also the other factors related to the coronary circulation. Okay, the other group of people, they never experience angina. If you ask them, did you ever have chest pain? No, sir. Did you walk? Yes, sir. Did you play? Yes, I play tennis. Nothing happens. Because there is no dynamic occlusion there. The microcirculation is good, but the vessel suddenly got occluded because there is a rupture of the plaque, a vulnerable plaque, we'll see later. That vulnerable plaque ruptures and the thrombus occurs and occludes. All of a sudden, caught unaware, no time, no investigation, not on any medication. And the fellow may present with sudden cardiac death or acute massive heart attack. They say, he was there all right, sir. Within 1 hour he died. Massive heart attack, you say. Why is the massive heart attack? Because of the vulnerability of the plaque. It is a thrombosis, this one, and not the dynamic stenosis or microvascular. So, but that doesn't come under angina, but anyway, I'm telling such people in India are around 70%. 70% of our coronary artery disease is that route, a faster route, younger patient, caught unawares, no treatment, no evaluations earlier. And he requires immediate revascularization. Whereas these people give you time, you can plan the revascularization, electively you can do something for them. Okay. Now, there is no thrombosis here. Because this is not from the thrombosis, but this is from the microcirculation and also the dynamic stenosis. Then let's come to the, and you see, this is the course. Slowly it increases over a period of time. Microvascular angina, there is no dynamic stenosis, no thrombosis, but the microcirculation of the heart is at fault. That means the epicardial blood vessels, if you do an angiogram, perfect. Sir, angio is normal, sir. Sir, I'm getting pain, sir, whenever I have any walk or anything, I'm there. There will be ECG changes of ischemia will be there, not infarction. Ischemic changes will be there, but epicardial blood vessels will be not. What is that? This is called syndrome X. There's another syndrome X, which is called the metabolic syndrome X. We are not talking of that. We are talking about syndrome X, cardiac syndrome X. Suppose you get a short notes, write short notes on syndrome X. You are supposed to cover both metabolic syndrome as well as the microvascular angina. So this microvascular angina, the pathology is no thrombosis, no dynamic stenosis, and there is an angina at rest. These fellows will be having angina irrespective of whether the heart rate is more or not. because the epicardial blood vessels are normal, but the microcirculation or the capillary circulation of the heart is at fault. You know the macrovascular disease and the microvascular disease, isn't it? So in diabetes, so these are the people with microvascular disease of the heart and not the macrovascular disease, which can be treated by your angioplasty or bypass or anything. Whatever you do, it is only for the major vessels, even the bypass or even the this one, even the sort of thrombolytics or even the PTCA, whatever you do is only for the major vessels. And these people are not helped. Then how are we going to treat them? So you have to see that the microvascular circulation is improved. How do I do that? By reducing the endothelial dysfunction. What is endothelial dysfunction? Increase in lack of nitric oxide, increase in the ROS. How does it occur? Obesity, diabetes, hypertension, dyslipidemia, lack of exercise, all these things, smoking. If you control all these factors, microvascular angina can be treated. Of course, support with a little bit of vasodilators, coronary vasodilators. You understand? Here, microvascular angina is no dynamic stenosis, no thrombosis, only microcirculation. And you look at the stenosis, there is no flow limiting stenosis. Epicardial blood vessels are normal. Okay. Now you come to unstable angina. What is unstable angina? There is dynamic stenosis to some extent, there is microvascular dysfunction, and there is also a partial thrombus which has not totally occluded and produced a myocardial infarction. There is a little bit of vulnerable plaque. The plaque got opened, little bit of thrombus is formed, and thus thrombus is sufficient to reduce the blood supply, but not sufficient enough to occlude the blood supply. So such a situation is called the USA or unstable angina, which is a component of the acute coronary syndrome. And here you see, if you do this one, you can demonstrate a flow limiting stenosis across the blood vessels because there is already some amount of narrowing because of the thrombus there. This can progress on to ST segment elevation or NSTMI, or it can go back to chronic stable angina. So this is a fellow who is a Trishanku, who is neither a normal, chronic stable angina safer fellow, nor a danger fellow on the other direction, but a fellow who can go either in the right direction and then get into danger, or they can go into normal direction and this direction and may become stable. Now what is variant angina? Variant angina is there is an occlusive spasm. This is the pringimental angina. And microcirculation is perfect. It is the spasm, just like, sometimes the spasm of various arteries, likewise, this also goes into an occlusive spasm of the coronary blood vessels. And there is no thrombosis here. They don't require thrombolytics. They don't require any PTCA. No epicardial blood vessels are to start with very normal. And coronary vasospasm is relieved by CCBs, calcium channel blockers, are the ones which relieve the coronary spasm. And this is very transient. ECG shows transmural effect. That means the ST segment is elevated, but within no time, it comes back. We had several patients whom we thought they had infarction. We admitted them, and within few minutes to 1 hour, ECG has become normal without much of treatment. No vascular revascularization is done. And remember, if you do enzymes here, they are normal. Because there is no injury, there is no infarction. It is only ischemia. So you understand? You have to have a very clear picture of what you are talking about. Chronic stable angina, crescent angina, microvascular angina, unstable angina, and then variant angina. Because the ECG pictures of these will differ. That is the story. Let us go. So what is the time? Now it started at 9. Another 5-10 minutes we can. Chronic stable angina, dynamic occlusion, microvascular dysfunction, progressive. Microvascular angina, no flow limiting stenosis, angiography is normal, less severe form of IHP. And majority of the women who present with chest pain and ECG changes, you do a coronary angiogram. Angiogram is normal. That is called syndrome X, microvascular angina. Unstable angina, dynamic occlusion, microvascular dysfunction, active thrombosis need to be carefully watched, may be admitted for a day or two. They may progress on to infarction or they may become normal. Pringemental angina is a occlusive vasospasm of the coronary blood vessels. No microvascular dysfunction, no thrombosis. ST segment is grossly elevated, but returns to normal within no time. Enzymes are normal. Treatment is relieve the spasm, not sort of doing any procedures or thrombolysis or anything. Okay, let us see. Now, the microvascular angina, so throw some symptoms. So regarding microvascular angina, there is enhanced pain sensitivity. There is also microvascular dysfunction. Together, they contribute. So enhanced pain sensitivity means some people will start perceiving the pain, even if it's mild thing is there, they complain a lot. Other people will be able to have a higher pain threshold and they don't complain. That is one aspect. The other is microvascular circulation. So the people who have low pain threshold, low pain sensitivity, they don't experience the pain unless the complete occlusion occurs. And they are the ones who are dangerous, particularly diabetics, autoimmune autonomic neuropathy. There is silent ischemia going on, just like the silent hypoxia of COVID. Though there is ischemia going on, they will not report to us a comfort treatment because the pain sensitivity is rather blunted. Why? Maybe because of autonomic dysfunction, maybe because of diabetes, maybe because of certain medicines that they take. And BP medicines are notorious to blunt the pain response. If you are treating them with BP medications, the pain response is blunted. That you have to remember. Likewise, microvascular circulation may be on the lower side, like this is the graph here. It's about the microvascular angina. So microvascular angina, the epicardial coronary blood flow is absolutely normal. Angiogram is reported as normal. No significant coronary artery disease in the epicardial vessels. No indication for bypass. No indication for PTCA. No indication to do any thrombolysis. Cardiac microcirculation is at fault. Poor collateral connections. Younger patients. If the patient is older, what happens is the LAD tries to make friends with the RCX. The LCX tries to make friends with the RCA. So how they make friends? There will be collaterals. And if this is occluded, the flow comes from this side. If this is occluded, the flow comes from beneath. So this sort of collateral circulation to develop, age is a factor. In a young man, the collaterals are not well developed. If any one of the blood vessels is occluded, then they will have a frank infarction. But here is a microvascular disease. Majority of these people have cardiometabolic risk factors like diabetes, hypertension, obesity, dyslipidemia, physical inactivity, smoking, so much so the microcirculation is affected before the macrocirculation is affected. Macrocirculation to be affected, it takes years for the atherosclerotic plaque to develop and it become vulnerable and rupture. Whereas it gives time. Whereas here, the poor collateral connections and then younger age group, more common in women. This is called the syndrome A. ECG or TMT, if you do, TMT shows positive. So ECG may be normal. Do a TMT. TMT is repeatedly positive. Go to the lab, cardiac cath lab, do an angio, vessels are normal. Means what? You have to modify the risk factors more and see that they're controlled. This is a microvascular angina. Patient will be symptomatic. For IHD, they will be complaining in pain at rest. So what did we understand? We understood what is injury, what is ischemia, what is injury, what is infarction. We also understood what is transmural, what is subendocardial, and what is ST segment depression occurs. Transient, what will happen to the ST segment, permanent, what will happen, and also looked at the transmural and subendocardial table. We also looked at the coronary circulation, the 3 blood vessels, and they fill in diastole, the diameter, and all the stories. And we also understood much more about the 4 types of angina: chronic stable angina, microvascular angina, unstable angina, and pringemental angina. We understood all of them. We also knew about syndrome X now. Now, if the ST segment we said is the fate line, so this is the baseline here of the PR segment. Compared to that, is it depressed? Yes, here you can say how much depressed? You can say 1, 2, almost 3 small squares or 3 0.3 millivolts depression is there, which is very typical. Any depression of more than 2 or more small squares is significant. If it is only one small square, it's not significant. At least 2 or more in 2 contiguous or related leads. Okay, if this is called horizontal, very significant. Downsloping, even more significant. Downsloping ends with a inverted T wave. If it is upsloping, it is not ischemia. This point is called the junction point or J point. What is J point? Where the QRS ends and the ST segment starts. That junction is called the J point. So from the J point, it is pulled up this way, upsloping, unlikely to be ischemia. Can't say no, but unlikely. So you have to have either a horizontal depression or a downsloping depression. And that point is called the J point. The junction point of QRS and the ST segment is called. Always this is in reference to the baseline. So this is the baseline there, the TP segment and the PR segment there. TP is here before the P wave and PR is between the P and the QRS. And in relation to that, where is my ST segment? Which is significant? 2 or more millimeters in 2 or more contiguous leads or related leads. Okay? So this is about the ST depression, 3 types: downsloping, upsloping, and horizontal. Upward sloping ST depression segment is not indicative of IHD. It is called J point depression or sagging ST segment. We say it is ST segment sagging. That means here the J point alone is depressed, but not the entire ST segment. It's also called sagging ST segment, you say. And downward sloping or horizontal depression of ST indicates associated T wave inversion is quite significant of ischemic heart disease. When there is an ST segment depression, it is definitely not transmural. It is definitely not transmural. It is subendocardial, or it could be a complementary change in the opposite lead. For example, there is the L1, there is ST elevation. The complement of that is seen in the L3 because they are opposite leads. L1 is this side and L3 is downstate. So whatever the current on this one, if you say ST segment elevation, typical lateral infarction, you will have to get a complementary ST depression, which is not due to ischemia or injury of the inferior part, but this is a complement of that. We will see that when we see the ECGs. We are given only the chest leads, V1, V2, V3, V4. These 2 leads are anteroseptal leads. These are the anterior leads. These are the lateral leads. Anteroseptal, anterior, and lateral. From here to here, it is the LAD territory, left anterior descending artery. This could be due to the septal branch, before the septal branch, and after the septal branch, it will be here. And this is probably LCX. Sometimes, from the LAD, distal part of LAD also, it can give rise to. So if you see changes here, they are septal changes, anteroseptal. If you see changes here, they are anterior. If you see changes here, they are lateral. Here you see, is there any ST depression or not? Yes, there is ST segment depression. How many millimeters? Certainly more than 2 millimeters. Can I see in contiguous leads? Yes, this and this contiguous leads I am able to see. So this is a case of infarction. And it appears as though it is J point here because upsloping, but by the time we came here, we knew it is horizontal and it is horizontal. Okay, here it appears like a J point pull or a sort of strain pattern, but we see here it is horizontal. This is also horizontal, and there is 2 millimeters or more in 2 contiguous leads, particularly in the lateral leads. So we have to say this is a lateral wall injury or ischemia or infarction. This is not infarction because we don't have ST segment elevation or Q wave. This is, you can say, ischemia and associated subendocardial. At the most, it could be subendocardial. Okay. What is the heart rate here? Any ECG you see, start looking at the heart rate. 300, 150, 100, 75. So after 150 it is coming 140. 140 in an adult is a very tachycardia is there. That means because of the infarction, there is associated tachycardia. Note the classical ST segment depression. STs are seen in V4, V5, V6. In the lateral wall, ST segments return to baseline after sublingual nitroglycerin. This patient, we gave sublingual nitroglycerin and the ST segment, let's say, return to normal. Chest pain is precipitated by effort. Notice the tachycardia, the heart rate is 140. So after nitroglycerin comes back, then there's an ischemia, which is transient, and it is a chronic stable angina. Suppose it doesn't return to normal and the pain persists. Then it is ST segment is depressed, pain is persisting, ST segment is not returning to normal. Then it is instead of ischemia, it is injury. How do you distinguish between the two? Do enzymes. The one with angina will come back with enzymes will be normal. The one with subendocardial infarction or ST segment, non-ST segment elevation will have enzyme changes, persistent changes, persistence of the pain, hemodynamic changes will be there. Whereas in angina, there won't be hemodynamic changes. In infarction, there will be hemodynamic changes, persistent changes, ST segment continues to be depressed, and it will not come back to normal in spite of coronary vasodilators. And also the enzymes are elevated in case of injury, which is subendocardial injury. If it is ischemia, it will come back. With the history there, we can say it is ischemia and not injury, and then the heart rate is elevated because of the chest pain. Now, T-wave inversions, you see this L1, the T-wave is inverted. R-wave, of course, is just a complement of all the other waves. So T-waves are upright. AVL also T-wave inverted. And then the L2 also inverted. L3 AVF inferior leads are not inverted. Lateral leads V4, V5, V6 are inverted anterior and lateral leads. So there is a T inversion in the anterior and lateral leads, as can be seen in L1, as can be seen in AVL, as can be seen in V5 and V6, and V4, V3 also show the anterior leads. These are called symmetric T inversions. Symmetric cup-shaped deep T inversions. Okay? Symmetric cup-shaped deep T inversions are a sign of old ischemia, old infarction. They can be there with the old infarction. If there's sometimes asymmetric will be, one limb will be like that and it will be suddenly raising. Here this limb is going down and nicely coming up. This is called symmetric cup-shaped, this one, or in case of cardiomyopathies, it can occur. Or in case of severe left ventricular hypertrophy, it can occur. Is there LVH here? No LVH, because we are not seeing tall V5, V6 and deep V1 and the voltages in the L1 must be more than 11, AVL, and here it should be more than 13. So there is no LVH. What is the axis here? All four are upright, so axis is normal. There is no left axis, there is no left ventricular hypertrophy, but you still see these are the old changes of this. So T inversion and without T inversion, if there is an LAD stenosis, those with T inversion, the percent of patients who have T inversion present with LAD stenosis of more than 70% is around 80% of people present with the T inversion changes. Only 20% of people may not have T inversion changes when there is an LAD stenosis. Whereas when have a myocardial infarction or death, T inversions are quite common compared to those without T inversions. So these are having a prognostic as well as clinical significance also. Now, deep symmetric T inversions, this is ischemic T inversions are like this, I told you. Okay, they are very deep, they are symmetric, they may be associated ST depression also. Okay, in these leads you can see that. Whereas cerebrovascular accident, particularly subarachnoid hemorrhage, produces changes in the ECG which look like ischemia. There are also deep symmetric T inversions, but the ST segment is always on the baseline and the QT interval is much prolonged. See the QT interval here There to there, it's shorter, whereas from here to here, the QT interval, with a prolonged QT interval, normal ST segment, no chest pain, deep T inversion, that is subarachnoid hemorrhage or cerebrovascular accident. Apical HCM, hypertrophic cardiomyopathy. So see very tall hypertrophy left ventricle. You can see the tall waves in V3 and V4, and deep, very deep S waves will be there. And this is because of the hypertrophic cardiomyopathy. So looking at the T itself, you can say, yeah, this is looking like ischemia. This is looking like a cerebral problem. This is looking like a hypertrophic obstructive cardiomyopathy. Like that you can decipher depending on the selected examples of this. So what is the DD of people who have T inversions like this? Differential diagnosis is pericarditis. Also will produce T inversion changes. Bundle branch block. We don't see that because QRS is not widened. LVH. We don't see LVH because V1 we require a deep S wave. And of course, we don't have a full ECG. Doesn't look like LVH. Subarachnoid hemorrhage. Yes, this is a subarachnoid hemorrhage. So these are differential diagnoses of deep cup-shaped symmetric T inversions or ischemia, cerebrovascular accident, apical HCM, LVH, BBB, pericarditis. Of course, one part of the CVA is subarachnoid hemorrhage. Maybe I'll stop short here and go for infarction in the next class. So acute coronary syndromes we will stop in the next class. We have looked at the T waves and all the things. I'm going to stop sharing this, and any questions I'm prepared to answer. I'm very glad that 22 participants are there and use this knowledge in clinical practice. Very detailed way we looked at the ischemia and infarction and all that. So any questions from the PGs, I welcome. Please open your mics and don't feel shy and clarify your doubts. This is the situation when you are a student only, you can have doubts. Once you become a consultant, you will have doubts, but you will not be able to express to anyone. There won't be any teacher to tell you.